Excited to welcome on Maggie Schmidt. Now, Maggie is a PGY2 critical care pharmacy resident at the UNC Medical Center. Maggie, thanks for joining us. How are you today?
Of course, I'm doing great. How are you?
Doing great. Now, I hear that you were a dual threat in college because not only were you receiving your pharmacy degree, you were also playing in the University of Pittsburgh marching band, which is so cool.
Yes, I was. It was a lot of fun. I love going to the football games, and it was fun just bringing the school spirit, helping to provide that fun atmosphere. We got to do a lot of traveling too, which was really fun, and it was a great group to be around.
So, for those who aren't maybe as musically talented or as inclined as you are, take us behind the scenes here. What's one of the most unexpectedly challenging or hard things of a marching band performance?
I think one of the most difficult things, I mean, obviously there's the component of memorizing your music and
Yep.
memorizing where you have to go,
Yep.
but once you practice it enough, that becomes more second nature. But it's the some of the unexpected potential elements, and mainly weather is a big proponent. We've had multiple games where it's rains a lot, the field is muddy, and even if it's a turf field, the field gets still like wet and slippery. And during our pregame performance for Pitt, like we would run out of the tunnel and there were numerous falls, fortunately none by myself, but those could get pretty. But then it's hard because my tendency when I see something like that, I honestly start laughing, but then I have to focus because I have to
Yeah.
get back into, like, we're running
Got to
out
get in
into
the
the
moment.
field. But then sometimes too, there's like there could be a little pile up. So I think the weather is like key because our shoes are not that tractiony. And especially in high school, like when you march on grass fields in the muddiness, it'd be a mess. So
If
I
it's
think
even
that
in
the
high school, it's even
unexpected
half
elements.
grass.
Yes, yes.
So basically, once you have everything down, it's everything else that where the unexpectedness comes from.
Yes, yes.
The reason we are here, in our most critically ill ARDS patients, a standard of care at one time followed the famous words of MC Hammer: stop, paralyze. Is it time to rethink this pharmacologic treatment strategy? Maggie, take it away with your critical care clinical pearl.
Sure. So, acute respiratory distress syndrome, or ARDS, is a clinical syndrome defined as rapidly progressing respiratory failure with onset within 7 days after a known clinical insult or new or worsening respiratory failure, as well as bilateral opacities on chest x ray or CT that are consistent with pulmonary edema, not due to effusions, atelectasis, or pulmonary nodules. It can be classified by the 2012 Berlin criteria as mild, moderate, or severe based on the P to F or PaO2 to FiO2 ratio, being 200 to 300 is mild, 100 to 200 is moderate, and then less than 100 equals severe. Mortality increases as you increase in severity, with the mortality up to 45% in the most severe group. So pretty clinically, obviously scary sort of group. And since 2012, there's been updated global criteria that have been described to acknowledge that the onset may be a little bit more indolent in some different types of pulmonary insults, such as COVID-19. The global type criteria specifically adds a new category for non-intubated ARDS to account for patients on high flow nasal oxygen who otherwise meet ARDS criteria, as well as incorporates SpO2 to FiO2 ratios for stratification to account for resource limited settings. So there's obviously the management of ARDS is quite multifaceted, but the aspect I'm going to focus on today is neuromuscular blocking agents. So they have sort of two big proposed mechanisms of how these neuromuscular blockers work in ARDS. The first is reduced oxygen consumption, and this is primarily due to them producing a decreased metabolic demand for these patients in the setting of ARDS. And this helps to improve ventilator synchrony, which leads to improved ventilator compliance, as well as decreased incidence of barotrauma. The second mechanism is through a decreased inflammatory response. ARDS patients have high amounts of systemic and pulmonary inflammatory mediators, and specifically NMBAs help to reduce these, particularly via IL-6. So the role of neuromuscular blockers was primarily established by two landmark trials that I'm sure we've all heard of before, the Accurasis and the Rose trials. Accurasis was published in 2010 in the New England Journal of Medicine and studied 340 patients with early severe ARDS defined as a P to F ratio of less than 150. It compared cisatracurium 15 milligram bolus followed by a 37.5 milligram per hour infusion versus placebo for 48 hours. patients in both groups were deeply sedated. The Accurasis trial found a significant improvement in mortality at 90 days in the sesacurium group after adjustment for the baseline P to F ratios. There were significantly more ventilator-free days and days free of organ failure in the sesacurium group. 9 years later, the Rose trial was published in 2019, and it was designed to almost identically mimic the Accurasis trial, but it did have some key differences. Similar to the Accurasis trial, the Rose trial compared sesacurium 15 milligram bolus followed by the 37.5 milligram per hour infusion over 48 hours to placebo in severe ARDS patients defined with the PDF ratio less than 150, though the Rose trial had a much larger sample size, just over 1,000 patients. The biggest difference between the Accurasis and Rose trials was that the Rose trial utilized light sedation in the placebo group, typically defined as a target RASS score of 0 to -1. And additionally, there was the allowance for a sesacurium 20 milligram bolus in both groups for patients sustaining plateau pressures greater than 30 centimeters of water for more than 10 minutes. This trial was stopped early due to the futility of its results, finding no difference in death at 90 days between the two groups. Additionally, there was a significant increase in ICU acquired weakness in the sesacurium group at day 28, as well as an greater incidence of cardiac adverse events in the sesacurium group. So to sort of compare the two studies, Rose trial obviously had a larger study population that was also more reflective of our current sedation strategies, utilizing light sedations in patients not receiving neuromuscular blockade. There was significantly less utilization of prone positioning in the Accurasis trial as compared with the Rose trial, 16% compared to 45%. And in addition, the Rose trial had higher PEEP targets for their patients. Important to note, the Rose trial was also conducted in the United States, whereas the Accurasis was conducted in France. So talking about what our two different guidelines available for ARDS patients are, we have the ES-ICM guidelines published in 2023 and the ATS guidelines for 2024. Our European guidelines specifically state we recommend against the routine use of continuous infusion neuromuscular blocking agents to reduce mortality in patients with moderate to severe ARDS not due to COVID-19, and they list this as a strong recommendation with a moderate quality of evidence. They also state they are unable to make a recommendation for or against the routine use of continuous infusion neuromuscular blockers to reduce mortality in patients with moderate to severe ARDS due to COVID-19. However, they do add in there, saying specifically a clear protective effect for pneumothorax was found in the neuromuscular blocking agent group compared to controls in the 4 studies included. This finding may support the use of neuromuscular blocking agents in those patients at the risk of developing a pneumothorax. So kind of in big letters, it almost says no neuromuscular blockers, but then they kind of slip this in there that says, well, maybe it will be beneficial for people at risk of pneumothorax. So kind of leaves it up to the audience or the patient care provider to make that judgment call. And then the ATS guidelines kind of say almost the opposite. They say specifically, we suggest using neuromuscular blockade in patients with early severe ARDS. However, this is a conditional recommendation with a low level of certainty. And they specifically defined as early, meaning within the first 48 hours and with a P to F ratio of less than 100. In addition, they state neuromuscular blockers may have a greater utility in patients with ventilator dyssynchrony that is not mitigated by ventilator changes. And in addition, they state that either bolus or continuous infusions may be appropriate. So that perfectly leads me into my transition of talking about dosing strategies for neuromuscular blocking agents in ARDS. There's 2 sort of potential options: intermittent dosing or continuous dosing. Obviously, both the Accurasis and the Rose trials utilized a flat dose, but this was likely due to the thought that higher doses could reduce the inflammatory mediators in the lungs, as well as with the consideration for the research purposes for consistency amongst the groups, having standardized dosing to use across the patients. However, these higher doses may potentially lead to the overuse of paralytics, which can contribute to acquired muscle weakness, as well as prolonged duration of deep sedation for our patients. While a titrated continuous infusion is not what was specifically studied in the Accurasis and Rose trials, it is what is often utilized for practice for ease of titration, as well as shorter durations based off the patient's progression. There's limited data to compare intermittent dosing to continuous dosing. However, there were 17% of patients in the Rose control group that did receive boluses of cisatracurium at a similar rate as those in the intervention group. They found no difference in mortality between these groups, but again, this was a very small portion, just 17% of the control group. It's thought that intermittent dosing might more accurately reflect a patient's paralytic requirements, but at this time, we do not have a large randomized control trial comparing these two different dosing strategies. In addition, intermittent dosing requires more reliance on monitoring strategies, particularly ventilator synchrony for its use. Because the whole kind of thought behind it is that we sort of target these moments of ventilator dysynchrony in hopes that sort of helps the lung to recover and to recruit more oxygen. So we have to then be cognizant of how we're utilizing, what are we determining ventilator dysynchrony, how are we monitoring this consistently day to day in our patients, which can make this dosing strategy pretty tricky. But then there is the obvious bonus of sort of limiting the deep sedation as well as limiting the time on prolonged neuromuscular blockade. And while more research is needed in the specific areas, I am a little inclined to pursue its use as it may provide some of those positives I was mentioning of neuromuscular blockade while potentially mitigating some of the adverse effects. We have some work to go to figure out what are the best strategies for us to be able to appropriately and safely monitor and recommend intermittent dosing for these patients. Another key area to think about when we're thinking about medications for ICU patients is drug shortage considerations. Feels like almost every day we're running into a new drug shortage and we have to get really creative with some of our different strategies. I think we're all tired about hearing the fluid shortage right now, but that's the biggest one that we're going through right now. And you sort of never know what shortage might come next. So you always want to be thinking sort of 2 steps ahead and what might happen if we don't have the particular drug we're used to using. Obviously, the only neuromuscular blocking agent I've mentioned so far in this podcast was cisatracurium, and that's because it's our preferred option to utilize in ARDS patients, particularly because of its unique elimination mechanism, specifically via Hoffman elimination, which consists of non-enzymatic degradation that negates the concern for renal or hepatic impairment impacting its elimination. It's typically dosed via a 0.1 mg per kg loading dose, followed by a continuous infusion at a rate between 1 to 10 mics per kilo per minute. The consideration of drug shortages, however, sort of begs us the question of whether or not we might want to consider some of these intermittent dosing strategies in hopes to sort of limit the use of this drug, but still be able to utilize it when this is the one we have studied for ARDS, and this is the one we have a little bit more experience with. Currently, there's little data to support the use of any other neuromuscular blocking agents in the setting of ARDS besides cisatracurium, just based off the trials and literature that we have available. And being that there is not evidence to support other neuromuscular blocking agents in ARDS, I can't super confidently make a strong recommendation for what is the best alternative option, but just thinking of our other options, the most similar mechanistically might be atracurium, given its similar elimination mechanisms via the Hoffman elimination. However, this would likely come at the cost of increased adverse effects due to histamine release, such as bronchospasm, hypotension, and bradycardia. 2 other options could be vecuronium or rocuronium, but with consideration of their prolonged elimination with either hepatic or renal impairment has to be considered for our patients, as this might limit their utility in some of our patients with potential organ failure. Ultimately, if cisatracurium was not available, I don't think I would very strongly recommend the use of another neuromuscular blocking agent in the setting of ARDS, just because of our limited data overall for neuromuscular blocking agents, but especially for non-cisatracurium neuromuscular blocking agents. Something else that's key for pharmacists to be thinking about when we're starting these drugs with patients is monitoring. Obviously, it's pretty hard to monitor a patient when they're not able to move or to speak or to tell you how they're feeling or how things are going. So we have to think of other strategies to use for these patients. And there's sort of 3 main strategies that we have right now available, which are train of 4, ventilator synchrony, and the bispectral index. As of right now, we don't really have a strong gold standard or sort of standard across the board option that we utilize for our patients, just because there can be strengths and weaknesses to all of these different mechanisms. The more commonly utilized option is train of 4, which is a peripheral nerve stimulator that is utilized to test the degree of paralysis in our patients. And how it works is you connect the electrodes to a particular part of the body, either on the face, sort of near the eyebrow area, or within the arm, sort of on the ulnar nerves to stimulate within the finger reflexes. 0 twitches means that 100% of the acetylcholine receptors are blocked, which indicates that the patient is very highly paralyzed. 4 twitches, or the max amount of twitches, means that less than 75% of acetylcholine receptors are blocked, and likely means your neuromuscular blocking agent dose might need to be increased. However, there are limitations to this is with edema, hypothermia, and skin physiology, all limiting the potential accuracy of this. In addition, you have to be cognizant there's different levels where you can start the train of four monitoring at, and you have to sort of increase those levels to see at baseline what does your patient react to, and you have to keep that consistent every time you're testing these patients. And that's some training that might have to be implemented for your nursing staff to make sure we're always consistently monitoring these in patients. The sort of next sort of forthcoming mechanism of monitoring these patients is clinical assessment, particularly via ventilator synchrony. Unfortunately, this lacks a consensus definition, but it's generally guided by monitoring peak and driving pressures in our mechanically ventilated patients. The Rose trial did specifically utilize this for their boluses of the neuromuscular blocking agents, specifically when end inspiratory plateau pressures were greater than 30. And the last potential option that we currently have is the bispectral index, which processes EEG signaling to obtain a value reflecting consciousness with values ranging from 0 to 100. This mechanism isn't super well validated in the setting of ARDS patients using neuromuscular blockers. However, something that it can be utilized in is when your unit might be more, say, comfortable using this is the consistency. Ultimately, I think for no matter what monitoring strategy you utilize, you want to stick with it and be consistent with the way that you're measuring it, because even if, say, the bispectral index or train of four, maybe if for whatever reason, it's not the best option for your patient, but if you're consistently assessing it, it's going to be still consistent sort of readings of how increased or decreased their level of paralysis is. And ultimately, that's the most important thing for these patients, is making sure you're consistent in the way you're monitoring to ensure you're safely administering this medication. And then in terms of safety considerations for these patients, obviously you see paralytic agent on the vial label, and it's really scary because it is. You don't want your patient to be paralyzed and not adequately sedated. So you always have to make sure that there are adequate sedation before starting the paralytic, specifically with a RASS score of -4 to -5. And something key to note is once you get them to that RASS score, you park the sedation there until you're done with the paralytic. You don't want to be making changes to their sedation while they're on their paralytic, because that gives you the risk of being under sedated while on a paralytic, which is something I don't wish upon anyone. In addition, neuromuscular blockers come with the risk of acquired muscle weakness after their prolonged use. And in addition, back to the fluid topic, you have to be considerate of how much fluids you're administering for these patients. Continuous infusions could acquire an extra 1 to 2 liters of fluid, depending on what their rate is and how long they're on the infusion. And even outside the setting of potential fluid shortages, being cognizant of the sort of conservative fluid strategies that we utilize in ARDS patients, you might want to be cognizant of how much additional potentially may or may not be necessary fluid for these patients. One of the new exciting areas in ARDS that I'm excited to learn more about is phenotyping. So it's kind of a new buzzword that I feel like we've been hearing about, but we don't know a ton about for ARDS. And by what they mean by phenotyping is knowing that the P to F ratio classification of ARDS does not consider that ARDS can develop from idiosyncratic insults to the lungs, such as pneumonia, aspirations, direct trauma, inhalation injuries, or drowning. And given the heterogeneity of the syndrome, there has become increased interest in evaluating ARDS in more of a personalized manner via phenotypes. The most consistently defined ARDS phenotypes are hypo and hyperinflammatory, which is demonstrated by the levels of pro-inflammatory markers such as IL-6, IL-8, and TNFR1. These two phenotypes have been shown to have differing responses to different PEEP strategies as well as conservative fluid strategies. Thinking mechanistically, having the most derived benefit in the hyperinflammatory patients makes sense when considering the damage associated with immune cell mediators during the exudative phase of ARDS. Evaluation of the Rose trial based off inflammatory phenotypes did find a trend towards a greater benefit in patients with greater inflammatory processes. And though there isn't concrete evidence in this area to suggest that targeting neuromuscular blocking agents based off phenotypes, this is a really exciting area that I look forward to seeing more future studies on throughout the remainder of my career. To sum up all of that, I know this was an exciting topic and one that can be definitely full of controversy, and it can be challenging because we don't have all the ideal data that we wish we have. We wish we had data looking at intermittent dosing versus continuous dosing. We wish we had data looking at this different inflammatory and hypo and hyperinflammatory phenotypes. But to summarize, the use of neuromuscular blocking agents in ARDS is a topic that can have a lot of these controversies, but we have to keep in mind all of these recommendations are potentially low quality recommendations with conditional recommendations of evidence. So we really have to keep in mind, what do we think is going to be the best option? What are the risks and benefits for using these strategies for our patients? Given the data and guidelines propose differing recommendations for the use of neuromuscular blockers in ARDS, it naturally comes as a case-by-case and patient-specific decision to pursue the use of these agents in ARDS. While sticking to continuous infusion is a strategy that is most formally recommended, I am inclined to start considering the use of intermittent dosing, especially as more data could be coming out to support this. I've kind of hit on this before, but I think it kind of targets the benefits and increasing ventilator synchrony and limiting the deep sedation and prolonged neuromuscular blockade while still having those benefits, but then limiting the adverse effects. And lastly, the differentiation of ARDS between the hyper and hypoinflammatory phenotypes maybe help to elucidate which patients might derive the most benefit from neuromuscular blocker use. And I look forward to seeing future research in that area as well.
I love that. I could talk about neuromuscular blockers and ARDS literally all day. But I have a question because when I hear your awesome Pearl giving us a lot of tips and tricks, one of the biggest things was monitoring and consistency in things. And I think that as we get bed shortages and things, sometimes you'll see these ARDS patients in units that aren't necessarily medical ICUs or even like a respiratory or pulmonary ICU, right? They might be neuro or things like that. So, if you were tasked with kind of educating nurses, new nurses, or other people, other folks at the bedside about safe practices with neuromuscular blockers, what would be some important tips as we may see some of these patients in other areas?
Yeah, I think this is a really vital role of pharmacists and something that we can play a really unique part in patient care. Is we know the dangers and potential adverse effects with these medications, and our job is to educate our nursing staff on this. I think some of the biggest key things that you have to be thinking about is one, the sedation, making sure the sedation rascal 4 to 5 when you start, park it at there and do not stop it. I think I like to recommend using like a do not titrate order in these settings. Once we get their sedation wherever we want it to be for these patients, just adjust the order to say do not titrate, so there's not even the chance that they might go down with sedation. But obviously educating the nursing staff as why we're doing this. We don't want to go down with sedation until the paralytic is off and we know it's worn off for the patient. The next biggest thing is the consistency of monitoring. First part is making sure the nurse that's covering this patient has utilized these different monitoring devices before, whether it's the train of 4, the BIS, or if it's going to be via ventilator synchrony, making sure they're aware of how to use it. And if they're not, do some teaching on it, or maybe find another nurse on the floor who has experienced these a little bit more so they can sort of help care for these patients. And then once we decide which monitoring mechanism we're going to use, making sure we're consistent with it, but also teaching everyone when their shift change, we're having new people relaying what happened with the patient, some from morning to night, the next day, keeping track of, for example, when it's with train of 4, what level did you have the train of 4 at before you triggered for it to do the twitches? If they're having 4 twitches at 2 and then they have it turned up to 8 and they're having more, well, if they're having it at 4, they're having it at 2, but you know what I mean. If
Yeah.
you're not triggering them at higher settings but then not at lower settings, you need to be cognizant. So making sure, I know when we have it for our patients, we always have something like a whiteboard on the window in the room saying like train of 4, set to 5, 3 twitches. So being cognizant of that and just making sure that the communication is consistent with the nursing staff, as well as like whenever shift turnover. I think those are the 2 biggest things. They're not as scary as they thought they were, but they're still something that you really need to be conscientious of. And then also to considering duration of utilizing these. Obviously, Curasis and Rose trial, they pretty much capped it at 48 hours, but thinking, is that what makes the most sense for a patient? And can we potentially get rid of it sooner if we see our patient maybe deriving benefit from getting it, but also being able to pull off of it. So I think those are the areas where pharmacists play a vital role thinking about neuromuscular blockers and ARDS.
Well, Maggie, thank you so much. This was awesome. Everybody definitely reach out to her, let her know how awesome of a job this was. I greatly appreciate all your time, effort, and energy helping bring this crucial clinical pearl to the masses. I appreciate you.
Thanks. I had a pleasure being here.